Okay, so welcome everyone. Thank you for joining us. I'm happy to introduce our speaker, Desiree Nielsen. She is a registered dietitian in Vancouver, Canada, with over a decade of experience in plant-based nutrition and chronic digestive and inflammatory disease. She's also the author of two Canadian best-selling and award-winning cookbooks, Eat More Plants and Good for Your Gut. And her latest book, Plant Magic, is arriving this month. We're actually doing a really fun giveaway with that. So follow us on social media to see that. Her work has been featured in People, Washington Post, The Globe and Mail, KTLA, WGN Chicago, The Social, Food Network Canada, and Elle Gourmet Canada, in addition to hundreds of media features across North America. Desiree is also the host of the evidence-informed wellness podcast, the All Sorts podcast, where she hosts a diverse roster of guests from New York Times bestselling authors to leading health professionals and researchers. So definitely check that out. And with that, Desiree, I'll turn it over to you.
Thank you so much, Megan and Jocelyn. I am so excited to be here to talk to you about this topic. I have been working with the low FODMAP diet for well over a decade, back when it was still deemed extremely controversial. And so I'm really glad that we are in this place today, understanding that it's such a powerful potential tool for our patients and clients with irritable bowel syndrome. But there's also something happening in the research right now looking at conditions beyond IBS. So, is there a place for low FODMAP in these conditions? That's what we're going to talk about today. So, hi, I'm Desiree. No need to, belabor the introduction. Like I said, I have 15 years of experience in chronic inflammatory and digestive diseases. I'm also plant-based, so that's another sort of core interest of mine. I write cookbooks and I own a private practice here in Vancouver with those three focuses. Some disclosures. I run my own business, but I do often work with brands such as, FODMAP and BioK. So I do a lot of education and collaboration work on social media with these. So that's sort of like the client base in the last year in terms of speaking and consulting fees. And I have received a speaking fee for this learning activity. So what we're going to talk about today, we're going to start just making sure everybody's on the same page about low FODMAP and how it potentially works in the body. And then we're going to get into condition-specific applications. We're going to talk endometriosis and PCOS, celiac disease and IBD. And then we're going to close with some best practices for implementing low FODMAP or not with our patients and clients in these conditions. So let's start by having, a simple understanding and then a deeper understanding of low FODMAP, just so we're on the same page. So of course, the FODMAPs are the fermentable oligo di and monosaccharides and polyols. These are highly fermentable carbohydrate molecules that by definition, by crook of our physiology or their chemical structure, not fully broken down and absorbed into circulation. Therefore, they remain in the digestive tract where they can interact with our gut tissues and the microbiome themselves. These are things like fructans and GOS in chickpeas, fructose in fruit, lactose in dairy products, and sugar alcohols. So how do FODMAPs interact with digestion? There are two main ways that we focus on. The first is that, like I said, anything that is not 100% digested and absorbed into circulation remains in the digestive tract. And these osmotic sugars, which are fructose, lactose, and then the polyols, they can draw water into the bowel, increasing the potential for luminal distension. And of course, when there's more water in the bowel, loosening up the stools. But all FODMAPs promote fermentation by the gut microbiota with the potential for gas, luminal distension, and pain in those with hypersensitivity. And there are a whole host of ways that FODMAPs can interact with the gut microbiome. And I want to lay this foundation before we get into these disease-specific applications. So the first is that the FODMAP elimination diet may produce alterations in the gut microbiota in the research. although this is rather inconsistent. And conversely, we understand now that the type of gut microbes you have in your digestive tract might actually help us predict your future low FODMAP response. And we know that when we're altering the gut microbiome, we also have the potential to impact things downstream. For example, the microbiota synthesize multiple metabolites that can influence neuroimmune metabolism. These are things like short chain fatty acids, like butyrate, which many of us have heard of, but this also means things like tryptophan, glutamate, GABA, and serotonin. And we have a recent systematic review that looked at the question of the low FODMAP diet on the colonic microbiome. And this is really important because there is a lot of back and forth, specifically around low FODMAP, around the safety of your gut microbiome health. And so this systematic review looked at 9 trials and was only 403 subjects. And what it found was, on average, there was no reduction in alpha, so within subject or sample diversity, or beta diversity, so the diversity of the microbiome with amongst samples. The only really consistent change was a reduction in bifidobacterium species. And this makes a lot of sense from a functional standpoint, because the FODMAP fructan, which is found in wheat, for example, is utilized by bifidobacterium. So now that we've started with the microbiome, how can FODMAPs potentially interact with inflammation and pain? We know that when visceral hypersensitivity is present, colonic gas production can influence pain. And this is a really important key, particularly in irritable bowel syndrome, is that it's not necessarily that there is an excess of gas production in IBS, but the gut-brain axis has developed a visceral hypersensitivity so that the production of gas itself is triggering this pain response. And we know that this neuroimmune activation is implicated in chronic pain onset, which for some of the conditions with chronic pain is an interesting observation. And I think one of the things that's really important to mention at this point is that this presentation is not going to solidify the science in our minds and say, oh, this is what we know is true, and this will always be true. There are a lot more questions than answers presented at this early stage in the science, particularly when we're looking at low FODMAP outside of irritable bowel syndrome. So we know that if we're augmenting the microbiota potentially with FODMAPs, that short chain fatty acids, if they are also augmented, they can influence localized inflammation. And there are also enteric-derived or gut-derived hormones such as serotonin and GLP-1, which are thought to influence visceral pain as much as things like serotonin also interact with motility in the gut. They can influence visceral pain. And it's thought now in the early research that the microbiome can influence visceral pain itself. And we've seen some early studies on probiotics and visceral pain that have been shown to be a success. We also have preclinical research that suggests that the low FODMAP diet may decrease visceral hypersensitivity. And the hypothesis is that it does this via decreased lipopolysaccharides, which are fragments of gram-negative bacteria that can influence permeability of the gut, as well as chronic inflammation. So now that we have that sort of baseline and all the ways that low FODMAP may augment the microbiome, inflammation, pain, now we can take a look beyond IBS, starting with endometriosis. So what is endometriosis? It is a chronic estrogen-related inflammatory condition where the endometrium, the uterine lining, develops outside of the uterine cavity. And this is typically within the pelvis, but it can be elsewhere in the body: fallopian tubes, ovaries, bladder, and intestines. It affects approximately 10% of menstruating adults, and it presents with chronic pain in the abdomen, dysmenorrhea, so alterations in menstruation, painful urination, bowel movements, and/or intercourse. Infertility is common in endometriosis, and early research also suggests that the cervical microbiota may be altered in this condition. And as with some things like celiac disease, there is a huge average time to diagnosis, somewhere around the neighborhood of 7 to 12 years. And if you noticed in that previous slide, there is considerable overlap with IBS, namely that this is a multifactorial pathophysiology with presentations like dysbiosis and inflammation. There are abdominal symptoms like pain and bloating, and misdiagnosis and delayed time to diagnosis is common. And we know that those with endometriosis share a 2 to 3 times risk of IBS, and approximately 20% of those with a diagnosis exhibit IBS symptoms. So we see not only overlap in the type of condition it is and the challenge to treat the condition, but very literally, we see people with endometriosis having increased diagnosis of IBS. So this is probably a good time to introduce you to the concept known as the estrobolome. And this is a group of bacterial genes that may influence estrogen metabolism. So we know that certain species of gut bacteria may harbor estrogen metabolizing enzymes, and they can impact the enterohepatic circulation of estrogen. This is similar to the way that the microbiome can influence enterohepatic circulation of cholesterol. So the microbiota may deconjugate bile-derived conjugated estrogens and testosterone, allowing reabsorption or hindering reabsorption. And the microbiota differences may be seen in endometriosis. So this is an interesting, again, more questions than answers, a really interesting connection here. We also know that a short chain fatty acid known as butyrate may have the potential to modulate progesterone levels. So let's look a little bit deeper into the microbiome and endometriosis. We see that dysbiosis present in endometriosis favors gram-negative bacteria, and that is connected to those lipopolysaccharides, which can influence not only neuroimmune responses, but contribute to chronic inflammation and gut permeability, and contribute to an immunosuppressive environment that may enable the ectopic endometrial cells. We also see that microbiome changes, as we mentioned, because of the estrobolome, may influence estrogen metabolism and inflammatory status, and endometriosis is an inflammatory condition that may play a role here. We do have a little bit of clinical evidence. So there was a 2017 study looking at endometriosis in patients with irritable bowel syndrome. And what it found was that there was a greater than 50% reduction in GI symptoms after 4 weeks in those with both IBS and endometriosis. And women with endometriosis versus IBS alone had a 3-fold increase in positive response to a low FODMAP diet. It's just one study, but it's definitely intriguing. So when a low FODMAP diet may be helpful, it's important to remember that diet has the potential to augment both estrogen and prostaglandin metabolism, as well as inflammatory status, and both of those things will contribute to endo outcomes. Things like caffeine, alcohol, phytoestrogens, fatty acids, omega-3, omega-6, as well as fiber. And bacteria will impact the health of your digestive barrier, as well as how your nervous system and immune system, because this is an inflammatory condition, functions. If digestive and inflammatory symptoms persist despite standard nutritional care, low FODMAP may be an option. But of course, you want to use everything in your toolkit before you're adding this extra level of nutritional effort or nutritional restriction. All right, on to polycystic ovarian syndrome. This is very much like a broad swath. This is a Coles Notes version, hopefully giving you some insights, because one of the things that I find after 15 years of practice is that even within evidence-based practice, there is often a gap between what we have access to in the scientific literature and the needs of the patient or client sitting in front of us. So even at this early stage in the research, it's really important to have an awareness of it, because when you have more tools in your toolkit, there are more potential ways to support, particularly when standard care has not produced the results or the symptom relief that your clients are looking for. So that being said, let's talk PCOS. So polycystic ovarian syndrome is an endocrine disorder characterized by chronic anovulation, so lack of ovulation, hyperandrogenism, and the polycystic appearance of ovaries. They're not actually cysts, but it's the appearance of the ovaries upon scan. This affects approximately 5 to 15% of menstruating adults. There is increased risk of infertility. Insulin resistance is often present, as is dyslipidemia and hypertension. I also want to mention here, because this is a nutrition presentation, that there is a significant mental health comorbidity and also significant weight stigma in this patient base. Really important to keep in mind as we're counseling nutrition here. We also see in PCOS that increased digestive symptoms are reported. So the hypothesis is that altered microbiome as well as increased intestinal permeability may be at play. And early research does suggest that there are higher rates of IBS in those with polycystic ovarian syndrome versus controls. There's a meta-analysis in 2023 that confirmed a twofold risk of IBS in PCOS. And here it's thought that estrogen may impact the visceral hypersensitivity in the gut as well as alter motility. So when there's altered estrogen and androgen production, we might see a change in digestion. What about the microbiome? We have a 2021 systematic review which confirms that there are differences in the microbiome of those with PCOS. It's a microbiome that's associated with insulin resistance, again, those gram-negative bacteria-derived lipopolysaccharides and inflammation. The microbiome is also influenced by sex hormone production. So it can be influenced by, but also have an influence. It's a cycle here. So we think that dysbiosis may be spurring androgen production by the ovaries, and certain species of bacteria might actually have a negative correlation with hormones like ghrelin and PYY. So in terms of increased appetite and weight gain, there could be an interesting microbiome component there. The provision of probiotics has also been tested in some trials and has been shown to impact features such as testosterone levels. Mechanisms. Why might this all be happening? So gut microbiota can affect human health in multiple ways, from altering, like I said, LPS and the chronic inflammatory state. It can alter intestinal permeability, and there is a connection between intestinal permeability, inflammation, and distal insulin resistance in the tissues. Short-chain fatty acid metabolisms can also have an impact on insulin resistance, IR, and can lead to increased androgen production. Short-chain fatty acids have their own impact. We're also looking at the bile acid pathway as well as the brain-gut axis. And this speaks so much to the challenge of conditions like IBS, like endometriosis, like PCOS, because they are multifactorial, because they have a potentially deeply complicated pathophysiology. Determining the role of nutrition and the best way to apply nutrition in order to produce the desired outcomes is deeply complex. So when we're looking at low FODMAP, it's really important to remember that specifically for PCOS, we don't actually have any current data on low FODMAP for altering PCOS characteristics here. However, when IBS symptoms overlap with PCOS and the desired symptom relief cannot be found with standard nutrition care, that's when you might actually want to consider a low FODMAP diet. There are some PCOS-specific considerations, however. Insulin resistance and cardiometabolic health mean an additional layer of dietary structure on top of low FODMAP, particularly where low FODMAP alternatives may be higher in glycemic index and glycemic load and may be lower in fiber, because both of those things are going to be of clinical consideration in helping to manage the insulin resistance of PCOS. The other thing we also need to consider is significant risk for disordered eating and mental health concerns because of the weight stigma, but also because of the stigma and the mental health concerns around chronic disease in and of itself. And so sometimes a patient or a client with PCOS might not be a good candidate for low FODMAP because the challenge of additional dietary restrictions will be too much from a mental health perspective, or may shift someone into disordered eating or someone who has a history of disordered eating. So let's talk celiac disease next. What is celiac disease? So it's an autoimmune disorder triggered by gluten ingestion. It affects approximately 1% of the population. You must have the genetic predisposition in order to then have that trigger that flips the switch on the disease. Classic symptom presentation is largely digestive: diarrhea, bloating, abdominal pain, unexplained weight loss. But the so-called silent celiac disease is possible and quite common, where a patient may come onto their doctor with only an unexplained fatigue that's anemia, not explained by diet. And then the physician digs a little further, and then it's like, oh, you have celiac disease. And celiac disease is unique in that it is the only autoimmune condition treated by diet. Treatment is a strict gluten-free diet for life. And of course, dietitians play a large role in helping those with celiac disease manage their autoimmunity. So what about digestive symptoms? Because the idea with celiac disease, of course, is once a strict gluten-free diet is adopted, the digestive lining will heal, the autoimmune process will subside, and people will feel well. In practice, that's not always the case. And roughly 20% of those with celiac disease meet Rome 3 criteria for irritable bowel syndrome. We see dysmotility, continued loose stools, or constipation. We see visceral hypersensitivity is very common in celiac disease. And we know that the chronic inflammatory process of celiac disease, particularly because, like endometriosis, there's often significant time to diagnosis, that it can not only alter the digestive surface of the gut, making things like lactose intolerance very common, but it can also alter the gut microbiota. And we do see a specific microbial signature in celiac disease. So some clinical evidence for low FODMAP in celiac disease. We're gonna start in 2018 and then work our way forward. So 2018 trial, N of 50, was a 21-day intervention. I love that they actually told us what the medium FODMAP intake was. It was 3.7 grams per day. After 21 days, there was a significant improvement in GI symptoms as well as psychological health scores with the low FODMAP diet. A 2022 trial, randomized controlled trial, N of 70, a 28-day intervention, a slightly higher, more moderate FODMAP intake, roughly 8 grams per day. And there was a significant improvement in GI symptoms, except for constipation, as well as an improvement in fatigue. So in celiac disease, is low FODMAP helpful? What should we consider? First things first, we are always ensuring gluten-free diet compliance to rule out as a cause of like their functional gastrointestinal symptoms. Maybe it's just that they're accidentally being gluten and that's causing a continued autoimmune process. We also have to consider that a gluten-free diet can alter the gut microbiome, particularly because gluten-free grains are often also low fructan grains, and having fewer fructans can change the type of bacteria, bifidobacteria, for example, as well as those that cross-feed on fructans. We also know that a gluten-free diet might be low in certain micronutrients, magnesium, iron. So if there's unexplained fatigue, we want, of course, be checking iron levels, zinc, manganese, and folate. And because we know that those on a gluten-free diet typically consume less fiber, we also have to know that a low FODMAP diet may exacerbate those fiber challenges, but otherwise we would not expect applying low FODMAP on top of gluten-free to add to potential deficiency states. The other thing we know is a dietary pattern. Gluten-free diets may also be higher in fat, sugar, and energy. All three of those things can augment the gut microbiota as well as digestion. So if we know that standard nutritional care, strict adherence to gluten-free diet, as well as ensuring basics such as fruits and vegetables, overall fiber intake, etc. Should those not produce results, it might be worth trialing a low FODMAP diet to assess benefit in this population. Next up, Crohn's and ulcerative colitis. So the inflammatory bowel diseases are on the increase. Crohn's disease and ulcerative colitis affect 1.6 million Americans. Here in Canada, we are on track for 1% prevalence, just as in celiac disease. These are conditions that are exemplified by cycles of flares and remission. We see protein energy malnutrition and common nutrient deficiencies, things like iron, B12, vitamin D. Nutrient intakes are also often inadequate. And one of the biggest reasons for that is that 60% of people with IBD tend to report dietary triggers. Working with a large IBD clinic for many years in my practice, it was exceedingly common that people with IBD would come to me with a very, very basic bland diet. Lots of white sandwich bread, lots of white rice, lots of, basic boiled or grilled chicken, often a lot of hyper-processed foods. Things were generally lower in fiber and would feel less irritating in the moment. And people often also avoid dairy because lactose, because of the inflammatory damage to the gut, lactose may become an issue, loosening up the stools, and people may have self-eliminated dairy as in hopes of managing this. So things like calcium, fiber, vitamin C, D, B1, B6, magnesium may be inadequate. And a 2022 case control study suggested that IBD, as I see in our own practice, can lead to increased avoidance and altered selection of foods, in particular, foods that are FODMAP sources. And a lower food-related quality of life score as disease severity increases is exactly what you would expect in this condition. So let's talk about digestive symptoms. One of the things that's very important to understand in IBD is that there are considerable pharmaceutical interventions, anti-inflammatories, we have biologics as well. But even those who are fully treated with the best that medical care can provide may not experience a lessening of their digestive symptoms. And here we see that 30 to 40% of those with the inflammatory bowel diseases may experience ongoing IBS-like symptoms. People in our practice, even on biologic medications, even on anti-inflammatories, may still have upwards of a dozen bowel movements a day with significant urgency, pain around the act of eating. And one of the reasons for that is this chronic inflammatory state that alters the digestive surface of the gut and also can influence the gut microbiota. So we do see a microbial signature of inflammatory bowel disease, significantly different for Crohn's disease versus ulcerative colitis, which is a little bit more overlapping with a normalized gut microbiota. So we see typical alpha diversity, so the diversity of species within sample or within subject, and the microbiota signature tends to be associated with a more pro-inflammatory status, which, as I mentioned, is more pronounced in Crohn's disease versus ulcerative colitis, where the inflammation tends to be more superficial and also more distal in the gut. With fewer lactobacillus species, Bacteroides and Bifidobacterium species, increased E. coli species. And I want to draw your attention to Faecalibacterium prausnitzii, which is a bacteria species that is thought to be anti-inflammatory and protective in inflammatory bowel disease. And this one is of interest because it is thought to be encouraged by fructans through cross-feeding. So not that F. prausnitzii directly utilizes fructans, but that the species that do utilize fructans then go on to encourage the growth of F. prausnitzii. Some clinical evidence here for you. Low FODMAP in IBD. We have a 2020 systematic review of a whopping 4 RCTs, really small number of subjects. Interventions were all very different in lengths. Oh, let's get rid of that little pop-up there. And very inconsistent findings because of that, inconsistent with respect to bowel movements and pain. We have a randomized trial in 2020, 52 people, a 4-week intervention, low FODMAP versus a sham diet. And it was found that low FODMAP was more effective at reducing bloating, improved symptom severity scores by 50%. And there was a more significant reduction in ulcerative colitis, interestingly enough, not Crohn's disease. There was no change in C-reactive protein or fecal calprotectin, which may help to sort of explain those results. But what's interesting here as well is that there was no change in overall microbiome diversity, alpha or beta diversity, low FODMAP versus sham diet. So again, adding to the complexity of, is low FODMAP altering the gut microbiome, particularly in a potentially harmful or negative way? But they did see lower bifido species as well as lower F. prosnitzi, again, that fructan cross feeder. Another one, 2022, really small. This was a feasibility study, N is 16, 8 weeks, ulcerative colitis and IBS as diagnosed by Rome 4 criteria, so stricter criteria, crossover elimination and blinded challenge, low FODMAP versus placebo. Here in 8 weeks, there was actually no change in symptom severity scores, but there was a pain and bloating decrease starting at 2 weeks. All right, 2022 study, again, low FODMAP diet in remission of IBD. So N of 65, this one was open, no control. It was a 6-week low FODMAP intervention. 66% of those with IBS eliminated their symptoms. Again, open, no control. There's a significant placebo effect in IBS studies that we see time and time again. So take that with a grain of salt. There was also no change in C-reactive protein or fecal calprotectin. But what was noticed was a larger impact in flatulence and diarrhea upon low FODMAP. So when might it be helpful? Research here amongst all of these conditions, but in IBD as well, it's very much early stage. But I think that it can be a helpful tool. And in the next section, I'm going to talk about one of the perhaps unusual ways that I use low FODMAP as a tool in inflammatory bowel disease for mitigating functional gastrointestinal symptoms. And also as a framework for increasing nutritional adequacy in the disease as well. So making low FODMAP work for your patient. Always, always in our practice, we're going to consider the least restrictive measures first. So we start with the basics. We start with nutritional adequacy. If they have celiac disease or IBD and their diets are almost entirely devoid of fiber, can we increase the fiber in a tolerated way? In our practice, we do this through multiple steps, particularly with our most inflamed clients, people with Crohn's disease, with multiple bowel movements a day. We will start with a framework of blended items, which is why I popped the smoothie picture up here. So for people who say, I can't eat a salad, it goes right through me, vegetables are just not for me, we will often do thoroughly cooked and blended. This is where blended soups can be really helpful, as well as smoothies. For people who don't eat any legumes, we might trial things like a bean dip, whereas they might not be able to handle a 1/4 cup of legumes outright, but maybe they can add a couple of tablespoons of a hummus to their sandwich to start getting in these essentially pre-digested forms of these fibers, these fermentable carbohydrates and these fibers in a way that might be better tolerated. Are people getting adequate protein and micronutrients to support growth, repair, and healing? And then also, because I see in celiac disease, but also in inflammatory bowel disease, a significant reliance on hyper-processed foods, and not necessarily because this is a budget issue, but because for those in IBD, they're looking for foods that are non-irritating in the moment. And of course, a low fiber food is going to feel best on the stomach now, but it might be contributing to an inflammatory pattern or a digestive pattern that will perpetuate symptoms in the long term. And for those with celiac disease, what I find is that hyper-processed and packaged foods with a celiac disease logo feel like a safer choice. And often people with celiac disease look for these options, forgetting that fruits, vegetables, legumes are naturally gluten-free and can also be a safe and healthy and important part of this diet. Also, increasing intake of prebiotics and polyphenol-rich foods where appropriate. For things like endometriosis, there is a significant inflammatory portion of this disease. So the more we can provide plant foods that offer these prebiotics to help support the gut microbiome, as well as polyphenols with antioxidant and anti-inflammatory potential, this is always a great thing in terms of general dietary pattern. And when we do these things and adequate symptom management is not achieved, that's when we can consider a low FODMAP elimination strategy. Of course, low FODMAP protocol, 3 phases: restriction 2 to 6 weeks, reintroduction, systematic reintroduction of specific FODMAPs, and then the customization phase. And I think what's really changed for me here in terms of low FODMAP for my clients in the customization and personalization phase is that the research on the potential of a low FODMAP diet to alter the gut microbiome is not as ironclad as we might expect. And so if we go through the customization phase and clients see that one or more FODMAPs are significantly driving their symptoms, that gives me more confidence as a dietitian to say, okay, so this is where we're at. Fructans and GOS, in order to manage your symptoms, we're going to maintain that elimination right now. And I'm less concerned, particularly because I know I can provide adequate fiber and other prebiotics in the diet to support the gut microbiome for these kind of eliminations long term. So this is one of the ways that I use low FODMAP diet in my practice that's sort of counterintuitive potentially to some people. And this is because I often see people in my practice with significantly restricted diets, whether they are influenced by people online or had healthcare practitioners tell them that soy is inflammatory or counter to endometriosis, or people go gluten-free because they have celiac disease, notice they have digestive symptoms, and then start eliminating other things because they read that this might contribute to digestive symptoms. So people will often come to me consuming very few foods and yet still dealing with these symptoms. And so there's a lot of fear and confusion around liberalizing their diet. And this is where sometimes I will use low FODMAP as a safe framework, explaining that if we are managing symptoms such as gas and bloating and pain from visceral hypersensitivity, low FODMAPs offer a lovely framework because we know that low FODMAPs foods will be less fermentable. So we can start to choose from our palette of low FODMAP foods to increase dietary variety, improve nutrient provision, as well as get more fiber back into the diet in a less fermentable way. So it often feels like a really safe structure for those who might be otherwise concerned about reliberalizing their diet. And then when we build tolerance, but also a greater sense of confidence, then we can start stepwise building in these higher FODMAP foods. Like I said, this might be the tablespoon or 2 of hummus on a sandwich versus actually providing chickpeas. So I use that a lot to sort of build people back up. We call it fiber training in our practice because, of course, sometimes these symptoms are caused by hypersensitivity and fructan intolerance, but sometimes they're caused by a lack of tolerance to these harder to digest and more higher gut residue foods in general. And we can actually build that tolerance back up, which is something we do a lot of in practice even with folks with celiac disease, Crohn's disease, and ulcerative colitis. And then for those patients and clients that we are using low FODMAP, it's really important that we're well versed in how to keep nutrition up so we're not compounding a lack of nutrition with a lack of FODMAPs. So we want to be watching out for calcium and magnesium intake. People can be consuming low lactose dairy if they choose not to, making sure they're using calcium fortified dairy alternatives. Of course, something like soy milk, unless it's made from soy protein, but whole soy milk won't be appropriate for low FODMAP, but things like calcium fortified almond milk will. Vitamin C, folate, riboflavin, fiber, those on plant-based diets. And I say this because oftentimes I will have people come to me where they've been told by their practitioner that because they choose a vegetarian or vegan diet, that they cannot be low FODMAP, or conversely, because they need to be low FODMAP at this point in their healing process, they can no longer be vegetarian or vegan. And it is very possible, but there needs to be a particular attention to protein. Low FODMAP proteins are far more in abundance than you might expect. Tofu and tempeh are two that I rely on a lot because they're very dense in protein. They're lower fiber and lower FODMAP, as well as hemp hearts. They're one of those things that I will add hemp hearts to everything, 3 tablespoons, 10 grams of protein. It's a really easy supplement to get more minerals into clients as well as protein while maintaining low FODMAP diet. And fiber is also extremely important. And I think that we can forget that fiber is important even within the low FODMAP sort of framework. And it's easier to keep fiber in the conversation than you think. And I mentioned here, particularly when we're talking endometriosis, fiber also moderates estrogen metabolism. So in terms of that enterohepatic circulation of estrogen that can be augmented by the microbiome, fibers can also bind estrogen in the digestive tract and carry it out of the body. So maintaining fiber intake is really important for helping to moderate estrogen metabolism. So what does a fiber-rich, low FODMAP day look like? This is not a huge volume of food for a very specific reason. I always aim for a lower volume of food to show people that it can be done, because you can always add more food, but I always want to counter the idea, well, that's more food or more energy needs than my client needs or that I need. So I want to show you how easy this is to do in terms of a single day of gentle, easier to digest fibers on a reasonable amount of food. There are so many gluten-free, low FODMAP bread products now with more fiber. So you might be surprised to see GF grain and seed bread, 5 grams of fiber, but they are out there. They're fantastic. And yes, you can always add more fiber, but there you go. 36.5 grams of fiber on a pretty small / average amount of food. Some really helpful tools in your toolkit. Of course, the Monash Low FODMAP app. You know, any list of low FODMAP foods is almost obsolete as soon as we publish it. So the app is fantastic because a client can keep it in their pocket, and when they're in the grocery store, remind themselves, oh, is this okay for me on this diet? It makes it really, really quick. They also have some useful journaling tools within that app, which are fantastic for then sharing data back with you, the dietitian, upon your follow-up. There are more low FODMAP recipe websites now. 5 years ago, it was very slim pickings, but now we're starting to see more free low FODMAP recipes online, which is a phenomenal thing for access. We also have far more low FODMAP condiments and prepared snacks. So things like marinara sauces or barbecue sauces or taco seasoning mixes that would have been impossible to find low FODMAP just a few years ago. Those are on the marketplace, both in major supermarkets and for purchase online. And for those of you lucky enough to live in the US, you can get low FODMAP meal delivery services. So for those clients where they want to do this, but time is just not on their side, this takes the guesswork out because you know that you've had professionally designed menus that are nutritionally balanced, and they just so happen to be low FODMAP so that it's a lot easier. Also, before we close and before we go to questions, I want to mention and remind you, really, this is just a reminder that sometimes low FODMAP isn't always appropriate. For that person who just has too much on their plate and the mental strain of dealing with a low FODMAP elimination is too much, it just might not be right for them, where dietary cost and having to change to potentially more expensive things, such as like low FODMAP grain products, for example, might be too expensive, or where there is a history of eating disorders or disordered eating, or where you are concerned that the stigma of adding dietary restriction to their chronic disease, their mental health load might not be right for them. There are many people for whom that might be the case. So you have a few options here as well. The first is a FODMAP gentle or FODMAP light approach, where it's not a blanket low FODMAP elimination, but you instead target the more FODMAPy or the more symptom inducing of the FODMAP. So they are here: cauliflower, the alliums, garlic, onions, leeks, for example, mushrooms, wheat, rye, fruits, milk, yogurt, and legumes. Enzyme-based therapy also exists for lactase and fructans and GOS. And so for the person who knows that this is a trigger or is wondering if this is a trigger, enzyme therapy can be really helpful because the enzymes help to break down those FODMAPs in the food, thereby lessening the symptoms that your client may feel from those 3 specific FODMAPs. And then, of course, a completely non-nutritional option exists and is backed by a little bit of clinical research as well, and that's gut-directed hypnotherapy. Great. So I managed to leave time for questions, which I'm feeling very proud of. So Jocelyn, we can head to the Q&A.
Wonderful. Thank you for a fantastic presentation. We've got some really good questions here. We'll try to get to all of them. To start off, we have a question from an anonymous attendee asking, what is the standard nutrition care you're suggesting before starting the low FODMAP diet? And I think that this question came around the time when we were on PCOS. So if you want to give a super brief overview of maybe the first line intervention you would do for that.
Absolutely. So standard nutrition care, the first line is always nutritional adequacy. So exactly what we would do with any client, ensuring that they're meeting their basic needs, macronutrient balance, getting enough protein, getting their omega-3s, getting their basic micronutrients as well. That is level 1. Level 2 for someone with polycystic ovarian syndrome is to help them manage insulin resistance and blood sugar control by doing, again, customization of diet. So looking at glycemic index, for example, looking at portions of different foods. Are they making half their plate fruits and vegetables where that is available and affordable to them, for example, quarter plate protein, quarter plate whole grains. If they are actively monitoring their blood sugars, you can then help them to customize their diet based on their own unique glucose tolerance. Helping them understand how big a portion of their starchy vegetable whole grains, or helping them understand the combination of protein, fiber, fat, and acid that can help them lower that glycemic response. So first is just nutritional adequacy. Second is evidence-based nutrition for managing blood sugar balance and insulin resistance. And then third, now that we're looking at potentially any excess digestive symptoms or that they're trying to treat, that's when low FODMAP is applied.
Thank you. So helpful. We've got a couple great questions from Susan here on celiac disease. So to start, in silent celiac, what are the most important labs that you would recommend checking each year after diagnosis, especially with a focus on micronutrients?
Yeah. So with celiac disease in general, whether it is silent or a classic presentation, the disease process is the same. Gluten ingestion, triggering autoimmunity, altering the digestive surface. So like that's the same no matter what. So we are always going to be looking at their antibody levels, their TTG, to make sure that those are remaining in the safe zone. They should come down with adults. This doesn't always happen in 6 months, 12 months, but that their TTG levels every year are coming down and hopefully going into a normal space for celiac disease within 2 years. Then we're wanting to make sure that we are taking a look at their thyroid and then looking at iron. Iron is number one, particularly for any menstruating adult, because iron levels are going to be a challenge.
Thank you. And that's a great segue into this next question. So continuing on celiac disease, if severely low vitamin D and ferritin persist with a strict gluten-free diet after 2 years following diagnosis, what could be the root cause or what's going on kind of behind the scene? And what other labs should possibly be checked, magnesium, anything else, and the ideal kind of treatment to promote recovery of these micronutrient deficiencies, of course, beyond a gluten-free diet.
Yeah, so when ferritin and vitamin D persist, low vitamin D persist, there is a question whether or not it's the provision of the nutrient itself or the inflammatory process itself that is causing these augmented labs. And so, of course, in low vitamin D, referring to the physician and potentially high dose vitamin D. In the US, you have access to different options than we do here in Canada. High dose vitamin D, I find, is not very often recommended by physicians here in Canada, but that is something that you should be talking to the physician about. And if the provision of high dose vitamin D is not improving things, if the provision of iron and iron-rich foods is not improving things, that's when I would be focused on inflammation. In particular, I would be looking at omega-3s. I would be looking at making sure that we're optimizing fiber so that we're hitting inflammation from the microbiome and gut barrier function perspective as well. There is some inkling, that's a whole other presentation, but there is some inkling that we can look at gut barrier dysfunction as we typically look at in celiac disease, as a measure of inflammation. And so fiber becomes really, really critical for that. Yeah.
Thank you. Yes, great paths to explore and consider.
Yeah, that's the least addition.
Here we've got another question. If on a gluten-free diet and exposed to cross-contamination in a college setting, but let's say any other setting as well, what labs might be low and how are they best treated given likelihood that they might have a future exposure or insult episode?
Yeah, so accidental gluten, wow, okay. Apparently my words are failing me now, but I only have 8 minutes to go. Okay, so accidental gluten ingestion is a reality for those with celiac disease. The TTG is going to show upon gluten ingestion, the TTG, those antibodies are going to go up. And so that's going to be like sort of a confirmation that that is occurring. The only thing you can do, I sort of treat accidental gluten ingestion like a flare in Crohn's disease or IBD. And that's when we go back to whatever is tolerable. And then, of course, with a mind of healing. So that's when we might be paring back on more insoluble fibers and leaning on our very gentle fibers. So this is where if they're tolerating, so things like ground chia, psyllium, getting those soluble fibers up can be really helpful in terms of soothing the gut. If they might be taking down, again, they're not tolerating things like the insoluble fibers from cereal fibers or raw vegetables, we might be offering cooked, easy to digest, maybe blended versions of those foods. Whatever they need to help calm their gut down is sort of like the way we go. Sometimes probiotics can be soothing in the moment. This is not really an evidence-based therapy for that, but I've found in practice, some clients do say, oh, when I take the probiotic, I feel a little bit better. You still have to allow time for the antibody reaction to come down. Probiotics are not necessarily doing anything there, but from the digestive perspective, they might help soothe the digestion.
Thank you. Yeah, great advice. Lots of interesting things to consider with our patients. Going to our next question, we're kind of venturing into the field of diagnosis. So if this is kind of outside of your wheelhouse, feel free to take a pass. But the question is, how is one with silent celiac definitively also diagnosed with IBD or Crohn's ulcerative colitis?
Okay, so someone with silent celiac disease, then diagnosed with IBD or IBS on top of that, I think perhaps is maybe it. So with celiac disease, so the diagnosis, so, and again, and this is something that their physician is going to do, but something I know enough about just to speak to briefly here. So silent celiac disease, like I said, even if people don't present with those symptoms, they will present with an elevated TTG and then go to their gastroenterologist for a scope, which is the gold standard. That being said, I do see a significant amount of GPs here in Canada, at least, who are diagnosing celiac disease based on the TTG results, at which point clients will often come to us and we'll send them back to their doctor to say, please, can we have a gastro consult and a scope, because that is gold standard. There's not much we can do beyond that if the GP isn't willing to do that. But if the TTG is positive, then it is extremely likely that celiac disease is present. Should people then adopt, and we're confident that they're adopting a strict gluten-free diet, and the TTG is coming down, so we know that the celiac disease, the autoimmunity process is going down, and then significant bowel movements, significant pain are coming, that's exactly when we send people back to their doctor. They need a scope. For IBD, they need a scope. Docs might also be doing things like fecal calprotectin as sort of like a proxy measure of inflammation in the digestive tract, but it is scope diagnosis. That is the gold standard.
Thank you. Great. Here we've got a question from an anonymous attendee. How do you manage an individual with IBS, chronic diarrhea, pain, bloating when all tests are negative for the likely suspects or diagnoses? So maybe IBS management is what this is getting
totally.
at.
And you know, this is so common to what we see in our practice. You know, a very typical client has been unwell for 5 years, 10 years, has gone to all of the docs. You know, we've ruled out all sorts of things. We've ruled out celiac disease, their symptom presentation, or maybe even they've had a scope and it's not consistent with something like the inflammatory bowel diseases, but they have significant pain. They meet the diagnostic criteria for IBS. And I think this is really important. And I just had a conversation with a gastroenterologist on my podcast a week ago that reconfirmed many people believe that IBS is a diagnosis slapped on someone when we don't know what's wrong with you. It doesn't appear to be anything else, so let's call it IBS. No, IBS has a very specific and well-defined diagnostic criteria. So ideally, if the doc is going through exclusion of other potential issues, like endometriosis, for example, I mean, we see this back and forth in practice where clients may come with IBS, they are not responding to any of the therapies, symptoms are continuing or getting worse, and 5 years later they are ending up, because infertility has come to light or painful intercourse has come to light, ending up getting an endometriosis, where endometriosis was a primary and it wasn't actually IBS. So it's not that that doesn't happen, but there is a really strong diagnostic criteria for IBS. And so when someone comes diagnosed with IBS from their physician, then the challenge is, how do we customize a dietary approach for this person? And like I said, in our practice, we will do the least restrictive things first. So upon presentation of a dietary journal, like diet and symptom journal, I see that there's significant room to move here on fiber, particularly for someone who's been diagnosed with IBS-C, but also with, IBS-D. Maybe I see that there is a lot of room here to move in nutritional adequacy. Fruit and vegetable intake is low. Micronutrients are likely low. Omega-3 is likely low. That is where we will go first. That's our first line of nutritional therapy. Then how they respond to that, whether we increase the fiber, and if there's a significant increase in symptoms where we just have to discontinue that fiber, that gives me another clue. We really work on this if this, then that approach to nutrition care. And once we've done those things, and we're like, this isn't working, this might be the time to entertain low FODMAP. That's when we'll then do a low FODMAP elimination. And again, assess. If they're feeling enormously better, we see that this is a FODMAP intolerance. And then we're going to start working on isolating and personalizing this diet for long term as we keep the fiber up, as we work on nutritional adequacy.
Thank you. Fantastic. So thorough. We are running up on time, so we're going to do one more question here. I'm going to skip around just to hop to one that I think is really important for us to address here as a final kind of wrap-up question, and that is, how do you screen for disordered eating or disorders as well?
Yeah, so it depends. It depends on the client. So we ask in our intake forms, in the medical history, we ask for previous diagnoses of eating disorders straight out. And so anyone who is willing to disclose that they have been diagnosed with, anorexia or bulimia in the past, they may disclose that at that point, and then instantly further food restriction is off the table. When we sit down for people, and that's the nice thing about, in our private practice, we sit down for people for 1 hour, in our initial. And so that's when we put our, counseling, investigative hats on and start looking for clues in how they describe their nutritional and medical history, look for clues in how they talk about their goals around nutrition. And if we sense that there may be some disordered eating patterns, we may ask some more questions just to probe, are there times where you ever feel out of control of food, or are there certain foods you're fearful of? Are there things that you wouldn't eat because you're worried that they're unhealthy or worried that they might trigger these symptoms? And we really use our counseling experience to sort of tease that out. And that's will help us determine whether or not we even sort of broach the subject of low FODMAPs. And this is where something like an enzyme that we suspect that maybe there's a little bit of FODMAP intolerance. And the way that we can know is there's this enzyme available that if we use the enzyme and you feel better, that gives us a clue. So we can use tools like that as opposed to elimination to give us some sense about where their tolerance is, without venturing into a restriction territory that might exacerbate those feelings.
Thank you. Great. Well, on behalf of all of us, truly have to thank you for your time, sharing your expertise with us. This is such a fantastic presentation. I'm so glad it's all recorded. I have a lot to reference back to. I will pass it to Megan just to conclude with some of the logistics.
Yes, thank you so much. So just a reminder, everyone, you'll get an email from me with your certificate of participation and a link to the recording. We will also share all of the ways you can find Desiree online, her books, all of that. So we will be sharing all of this after the presentation, probably will be tomorrow by the time I'm able to pull everything together. So yes, have a great rest of your day.